This presentation will cover mood disorders and grief in the older adult. I'm Dr. Jennifer Drost. I work at Summa Health and am an assistant professor at Neomed, and joining me to discuss grief is Reverend Shannon Blower of Summa Health. Reviewing this information along with the remaining information available on the SkyPrep app will provide you with basic information needed to participate in the interprofessional team meeting. The majority of this presentation is related to the depression and anxiety in older adults, and will discuss the effects of these illnesses, signs and symptoms, related medical function and psychosocial needs, treatment options, and finally we'll discuss the importance of loss and grief in the care of older adults. Let's start with another question. True or false? Depression is common in older adults and can make symptoms of other illnesses worse. So the answer to this is true. While depression is not a normal part of aging, it does affect 1 to 2% of community-dwelling older adults, and up to 15% may have subsyndromal or mild symptoms. It does affect function and independence as well as the person's ability to recover from illness. Up to 10% of hospitalizations have mood disorders that are contributing to the illness. Most importantly, depression is associated with an increased risk of death related to medical illnesses. True or false? Depression in older adults has few symptoms. So this is false. There are a wide range of symptoms that older adults suffering from depression may present with. Risk factors for depression include disability, bereavement or having lost a loved one, poor health status, increasing age, and being female. Functional decline is common in older adults with depression, and the inability because of weakness or fatigue to complete your basic activities of daily living, such as dressing or bathing, may result in hospitalization or nursing home placement. This is why it is so important to evaluate older adults for depression. So what are some other things you should think of when evaluating someone for depression? There certainly are medical illnesses such as hypothyroidism, cardiac or neurologic diseases which can present with depressive symptoms. They may be the result of medication effects or side effects. Substance abuse including alcohol, cocaine, marijuana, as well as opiates should be considered. Dementia, which we'll discuss further. Delirium. Grief and bereavement, and insomnia, which we'll also discuss. You should consider elder abuse and neglect, as well as how pain might be affecting a person. True or false? Depression and dementia are easy to tell apart. This is a trick question. Not always. Dementia is defined as a chronic decline in cognition that affects a person's ability to function and their activities of daily living. Depressive symptoms are common in a person who is suffering from dementia, but dementia symptoms progress slowly and occur over months to years. Depression, on the other hand, may cause memory problems. However, the symptoms often occur more rapidly. The diagnosis of depression can be made by using one of several different validated tools. The interprofessional simulations will use the PHQ-9 that's shown here. It's based on ICD-10 symptoms such as having little interest or pleasure in doing things, feeling sad or depressed, sleep disturbances, having poor appetite, feeling bad about yourself, etc. Higher scores, particularly those over 10, indicate more severe symptoms, and you should consider treatment. So the treatment of depression in older adults, it's important to consider both non-pharmacologic and pharmacologic treatments. This is why evaluation with a full interprofessional team is so important. Both modalities are often necessary to treat depression in this patient population, and so involving social work, counseling, mental health providers, as well as physical, occupational therapy, and increasing the socialization is all important. When we discuss medications, selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, as well as mirtazapine, are the mainstays of treatment. Let's switch focus and talk about anxiety for a few minutes. True or false? Older adults become more anxious as they age and face more health concerns. The answer to this is actually true. While anxiety, like depression, is not a normal part of aging, the rates of anxiety do increase as people age. Up to 10 to 20% of senior adults may be experiencing anxiety, and this can interfere with a person's functions, with their interpersonal relationships, and their ability to maintain their independence. True or false? Anxiety symptoms are unlikely to be caused by illness. And this is false. The differential of symptoms of anxiety includes endocrine and cardiac disorders, the effects of medication, depression and anxiety often coexist, as well as dementia with some differing behavioral symptoms. Similar to depression, there are screening and diagnostic tools that can be used for anxiety. Generalized anxiety disorder is the most common anxiety disorder that affects older adults, and using tools such as the Beck Anxiety Inventory, as shown here, have been validated in this population. The interprofessional team simulations will use the Beck Anxiety Inventory. Similarly, higher scores indicate increased severity of symptoms, and those with scores of 22 or greater should be considered for treatment. True or false? The treatments for anxiety in older adults have many side effects and are not very effective. So this also is false. There are a multitude of treatment options for anxiety in older adults, but like depression, often a multimodality and team-based approach is most appropriate for care. The treatments of generalized anxiety disorder, as this is the most common type in older adults, include certain medications, the use of therapies, including psychotherapy or cognitive behavioral therapy, lifestyle changes, aerobic exercise, and relaxation therapy. Medications used to treat generalized anxiety disorder include benzodiazepines. However, these should be only used for short term, less than 2 weeks. They are associated with functional decline, falls, and physical dependence. You'll hear more about those in other sections. Buspirone also treats anxiety, but it does not treat depression. Its peak onset can occur in 4 to 6 weeks. For generalized anxiety disorder, antidepressants are the mainstay of pharmacologic treatment. The selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors are the most common used. You might see some effect in 2 weeks, but 4 to 6 weeks are needed for full effect. Here are some additional resources available to you.
Hi, I'm Shannon Blower, the ICU chaplain and senior clinical educator for Summa Health Systems. I'm also a certified grief specialist. This section will address the impact of unresolved grief in geriatric patient care. It was Maya Angelou who stated, "There is no agony like an untold story inside of you." First, let's take a look at some medical observations on grief. Suppressed unresolved grief has a cumulative effect that negatively impacts health. Carrie Ram asserts that medical knowledge suggests that our bodies already know what our words have long implied, that grief can, quite literally, sicken. A study recently published in the journal Aging and Immunity found that among the elderly, in particular, the recent loss of a loved one may leave a person more vulnerable to infectious disease. This further exacerbates the dilemma of unresolved grief. Loss of health is yet another determinant to a patient's quality of life. Quality of life is a spiritual disposition realized individually by each person. Consider Deborah DeMore's understanding of spirituality as the life force heartbeat behind each person's life. revealed through the experiences and rhythms of one's lived biography, illuminating their discovery of individual identity, personal significance, and connectedness to the divine, self, and others. We begin to see then that cumulative, unresolved grief impacts more than the body, but the very mechanism for determining meaning and purpose. As you take a moment to review this slide identifying common losses, reflect on Dr. Druck's statement on the impact grief and loss has on older adults as they experience the loss of family members and close friends, further complicated by losses associated with identity, status, and independence. When serving geriatric patients, there are 3 additional types of grief that may require attention: complicated grief, disenfranchised grief, and anticipatory grief. Proper assessment involves hearing enough of the patient's story to tease out common grief dynamics. Consider these manifestations of unresolved grief that may not have a biological origin or remedy. Our last slide identifies 5 non-pharmaceutical interventions that provide possibility for greater functioning and life meaning: life review, faith rituals and practices, narrative therapy, grief recovery programs, and peer support. Robert Cavanaugh reminds us of potential unresolved grief residing in the hearts of older adults. Unopened, these pockets of grief block unimagined amounts of human growth and potential. Finally, unexplained patient behaviors may find their root in unresolved grief events.